Welcome back. So we left off part 1 with a question, and that was, how is it that we can have a cranial nerve 3 palsy that causes a blown pupil and another that only affects the extraocular muscles and levator palpebrae superioris? And I gave you a few clues to this. Number 1, I said that there's two different types of fibers, parasympathetic and motor fibers. And the other clue was that the way these fibers were organized within the nerve was important. So now, without further ado, let's have a look at the nerve structure. So here we have our cranial nerve 3 trunk covered in our nerve sheath. And as you can see from this cross section of cranial nerve 3, there's two different types of fibers within the nerve. And the central ones in green are the general somatic efferent motor fibers. And these are the ones that control the extraocular muscles and the levator palpebrae superioris. And they are distributed throughout the trunk. Now, arranged around these motor fibers on the periphery of the nerve are the general visceral efferent or parasympathetic fibers. And they're responsible for pupillary constriction and accommodation, as we've seen previously. Now, what about the blood supply? So let's bring that up here. Rich capillary network surrounding the nerve is called the vasa nervorum. And as you can see, the blood supply is coming from the outside and going in, so the core part of the nerve will be the most susceptible to ischemia. And on the other hand, the outside part of the nerve with the parasympathetic fibers delicately wrapped around it will be most susceptible to compression. Now let's have a look at an example of each of these situations. So what do we have going on here? We can see from this drawing we've got a large aneurysm compressing cranial nerve 3. And let's say that for this example, this is the posterior communicating artery. And in a moment, when we go through the course of cranial nerve 3, you'll see why I've chosen the posterior communicating artery. So this is our PCOM aneurysm, and it's pressing against the cranial nerve 3 trunk. And what I'm trying to demonstrate here is that the central green motor fibers are relatively unscathed in this. They may be a little bit more bunched, but they're not compressed. On the other hand, our general visceral efferent parasympathetic fibers, which are delicately wrapped on the periphery of the nerve, are the first things that are going to become compressed. And when we have compression of cranial nerve 3, the earliest sign will be our blown pupil. And that's the mechanism by which you can have our blown pupil without having the other changes. Now, if this aneurysm was to continue compressing the nerve, eventually you would get a complete cranial nerve 3 palsy. But the first thing that will happen with compression is that you will have the blown pupil. Now we've answered the first part of our question. Let's have a look at an example of cranial nerve 3 ischemia. So what's going on here is that we have a decreased blood supply to the core area. And the reason for that is that we have this very diseased vasa nervorum. This normally rich capillary network has lots of diseased, friable, leaky vessels. And what this drawing is trying to demonstrate here is microvascular disease, which is almost always associated with diabetes. So as we've seen before, the blood supply comes from the outside and goes in. Therefore, the area in the core is going to be the most susceptible to decreased blood supply. And that's why we have these motor fibers in the inside of the nerve that are now undergoing ischemic injury and necrosis, whereas the parasympathetic fibers on the outside are spared. And that's when we're going to see ptosis and our eye going down and out without any associated pupillary changes. So now let's have a look at cranial nerve 3's origin as we come to the conclusion of this video. And here we're looking at a sagittal midline section of the brain. The very upper portion of the brainstem is called the midbrain, and this is going to be home to our cranial nerve 3 nuclei. So let's zoom in, and at the level of the superior colliculus is where we're going to find our Edinger-Westphal nucleus. And this is the origin of the parasympathetic fibers. Now just below it, and again very midline, we've got our oculomotor nucleus, which is the primary nucleus of cranial nerve 3. Now the fibers running from the Edinger-Westphal nucleus are first going to go to the ciliary ganglion. So we have preganglionic and postganglionic fibers, and they're going to innervate the pupiloconstrictor and ciliary muscle. The fibers coming from the oculomotor nucleus, so our GSE fibers, directly innervate from nucleus to muscle. That includes levator palpebrae superioris, superior rectus, inferior rectus, medial rectus, and inferior oblique. Just take a moment to label the ciliary ganglion. So this drawing is conceptual. It's meant to show you that there's two different fibers within the nerve. But as we know from our previous segment, these fibers in fact run within the same nerve bundle. Now let's have a look at a more anatomical drawing and follow the course of cranial nerve 3 from its nuclei to the eye. So this is a transverse section of the brainstem we have at the top. And at the level of the superior colliculus, we have our oculomotor and Edinger-Westphal nuclei. As you can see, the nuclei are quite midline, and so is the nerve. It exits the brainstem ventrally at the level of the interpeduncular fossa. It then runs just below the posterior communicating artery. And it may not be the most obvious from my drawing, but it actually runs in close proximity to the posterior communicating artery. That's the one we saw earlier, whose aneurysm was compressing cranial nerve 3. And PCOM aneurysms are actually fairly common. Cranial nerve 3 then runs through the cavernous sinus. It then enters the orbit via the superior orbital fissure, along with the trochlear nerve, cranial nerve 4, and the abducens nerve, cranial nerve 6, as well as a number of other vessels that we won't get into here. Cranial nerve 3 then innervates the target structures we've already discussed extensively. Now this is a clinical tutorial, not an anatomical one, and the reason I've pointed out these structures specifically is that they have significance in cranial nerve 3 lesions, and they present common areas of pathology. Now to finish off this video, I want to anchor some of our learning today by going through some common pathologies very briefly with you. Now starting from the top, at the level of the brainstem, obviously we can have a brainstem stroke. This would be a posterior circulation stroke, which involves the vertebral portion of the circle of Willis. Because cranial nerve 3 nuclei are so midline, they often cause bilateral changes and will also affect the neighboring nuclei and other functions of the brain that run in the same area. So this would be a clue to that. And obviously a brain tumor could do a similar thing. Number 2, as cranial nerve 3 exits the brainstem and the interpeduncular fossa, it's susceptible to certain compressive conditions. One of them, which we have not discussed yet, would be brain herniation. Now, when you have increased intracranial pressure, the brain starts to push down on structures, and the uncus of the brain can compress on cranial nerve 3. Earlier in part 1, I mentioned that a blown pupil is often a sign of a medical emergency, and an emergency doctor would check for a blown pupil or a dilated pupil in his primary survey in a way to monitor neurological status. And this would be the scenario where that would happen. In a patient with a traumatic brain injury or a hemorrhagic stroke that has increased intracranial pressure. The other one that we've already reviewed would be the posterior communicating artery aneurysm. Next one would be an issue with cranial nerve 3 coming in the cavernous sinus. You can have an infection, a mass, an aneurysm, a tumor compressing on cranial nerve 3. And a clue to a lesion being here might be that in addition to affecting cranial nerve 3, it may also affect other structures that run in the cavernous sinus. This includes cranial nerve 4, 6, as well as the V1 and V2 portions of cranial nerve 5. And these can be quite tricky to work out because they may not be affecting all of them in the same way. Finally, we can have a retroorbital mass that affects cranial nerve 3 fibers, and it would also affect other structures coming through our superior orbital fissure. And the other one I just want to remind you, because we have covered already, is microvascular disease. And this can pretty much affect the nerve anywhere, from nucleus all the way down to the motor plate. Alright, that's all I have for today. I hope you find this clinically relevant and useful on the wards. I just want to point out to you that in practice, cranial nerve 3 lesions can be quite tricky to elicit. It's very useful to practice your cranial nerve 3, 4, 6 extraocular muscle exam in order to try to pick these out. Good luck. I hope you'll be able to diagnose cranial nerve 3 palsies and discuss some differential diagnoses of what might be causing it.